Hi, everyone. I know people are still coming in from the other session, but I'm going to get started because I know you want to have as much time with our speaker as possible. So as people come in, feel free to come to the front. There's plenty of room, and sit down and get settled. Well, welcome to your first plenary session. As you know, we're doing tracks at this conference, and this plenary session is for our hormone receptor-positive and/or ER-positive breast cancer. We're going to get a medical update. So there's lots of information on this particular topic. And remember, this is a medical update, and we have two parts, so we have lots of time to be together. I'm really excited to introduce you to your speaker for the morning, Dr. Hurvitz, who is coming to us from LA. She is a medical oncologist at the David Geffen UCLA School of Medicine and director of the Breast Center and Clinical Research Program. She has won numerous awards over the past years, and breast cancer is her specialty. She has a very active practice, so I think she has a lot to tell us, and she's very committed to compassionate care for her patients and has referred her patients to many places for integrative care, because we know that you need both Western and Eastern and all kinds of medicine to fight this disease. So I am going to bring up Dr. Hurvitz. She was nice enough to hand out her slides, but please don't rustle through the papers too much. And I just want to remind everyone, we are doing live video feeds, so we have an audience watching through the web stream. When she is finished her presentation, we will be taking your questions via text. So start thinking about what you need to ask and text them. If you're not able to text, you can write them down, and one of my volunteers will grab them. But remember, for our web audience, you'll be able to text questions as well. Okay, Dr. Hurvitz.
Okay, so let's see if this works first. There we go. It's a little slow. There we go. So we're going to begin by talking about the molecular subtypes of breast cancer. I understand you just had a lecture from a pathologist kind of giving you the background on the different types of breast cancer and how breast cancer evolves in the breast. So we'll touch on that a little bit and start with a history lesson, because I love history. It helps us understand why we do what we do today. And then I'm going to break it down by hormonally targeted therapies, focusing on the most commonly used therapies and how they work, and giving you an update on the most cutting-edge new therapies that are being tested or have recently become available. And then we'll move on to the HER2-targeted realm as well. Okay, I apologize. This clicker is a little delayed. So shown here is a picture of Sir William Halsted. Many of you may have already heard of William Halsted. He was a surgeon who was doing his work in the 1880s and actually pioneered a surgery called the radical mastectomy. The radical or Halstedian mastectomy involved removing the breast, all of the breast tissue, the pectoralis muscle, all of the lymph nodes in the area. It was a horribly disfiguring surgery that left a woman with a caved out portion in the chest wall. The reason that Halsted pioneered this surgery is that he understood breast cancer, or assumed that breast cancer could only spread to other parts of the body by following a very organized, orderly path through the lymph nodes and then on to the rest of the body. And if his assumption was correct, then doing more surgery would yield better survival. However, he never tested his theory scientifically by comparing it to less invasive surgical approaches. In fact, Betty Ford in 1970 had a Halstedian mastectomy. It wasn't until the mid-1900s that this theory was challenged. And so around the time that Halsted, sorry, this isn't responding. Around the time that Halsted was pioneering his Halstedian mastectomy, Rudolf Virchow, who was around the same time, had written a 3-volume treatise on the tumorous diseases. And what Virchow did was he was the first person to classify cancers in this book using a microscope. And the way that he classified the cancers is how they appeared under the microscope. He also classified them by the organ of origin. So if the cancer began in the lung, it was a lung cancer. If it began in the breast, it was a breast cancer. And then he subclassified the different types of breast cancer by the architectural pattern or the way the cells organize themselves under the microscope. And we're actually still using this classification system when we're teaching medical students in the United States and elsewhere about how to subclassify breast cancers. And the top one here, infiltrating ductal carcinoma, is the most common type of breast cancer that is diagnosed. Up to 80%, even 90% of patients have infiltrating ductal carcinoma. But this doesn't tell us anything about the behavior of that tumor, whether it expresses hormone receptors, whether it's more likely to come back later, is it fast growing or slow growing, and how should we best treat it? So this classification system, while it was a nice way of organizing the different types of tumors, for the majority of cancers, it didn't give us enough information about the best way to treat it or what a woman's prognosis would be. And so along came Bernie Fisher in the 1950s, and this is a surgeon back east who began to observe that some women in his clinic would have very tiny tumors, and he would do the Halstedian mastectomy, and a few years later the tumor would be back in the liver or the bone or the lungs as metastatic breast cancer. And he said, why is this happening? Even when the lymph nodes are negative, we're seeing patients have breast cancer come back elsewhere in their body. So, and then there are some patients who have very large tumors, and the tumor never comes back, even when it's very large. So he began to see and observe that breast cancer is not one disease. And he began to understand that breast cancer can spread to other parts of the body in a disorganized fashion. It can get right into the blood vessels within the breast tissue and travel to distant sites. It doesn't have to go through that orderly, contiguous path of lymph nodes onto organs. And so he understood that for patients with more aggressive tumors, doing a more aggressive surgery is probably not going to improve survival because we're not getting at those cells that already escaped the breast. And so he began to do a number of clinical trials to challenge whether or not we needed to do a radical mastectomy. He did a number of studies that looked at modified radical mastectomy, which was less tissue being removed, fewer lymph nodes, the pectoralis muscle was spared, and then he pushed the edge of the envelope and said, actually, I think we can do a lumpectomy. I think we can just remove the tumor and some clean tissue around the tumor and remove the lymph nodes and leave the woman with the breast, and I bet we can have the same survival if we do radiation after the lumpectomy. And he was right. He was absolutely right. Through a number of trials, he proved that. Something's going on with this. Sorry, guys. Okay, great. So the former treatment approach to breast cancer was we were focusing all on local regional treatment. Remove the tumor from the breast, remove the lymph nodes here. If you can do a lumpectomy, great. We can do radiation there, and that was that. However, Bernie Fisher said, you know what? If tumor cells have already escaped by the time we've diagnosed the woman with breast cancer in her breast, then we're not doing enough by just focusing attention on the breast and lymph nodes. We need to give medicine that goes throughout the body to kill those rogue cancer cells that have left the breast. And so he went on to do a number of clinical trials to look at giving a course of chemotherapy around the time of surgery. He randomized these trials where half the patients would get chemo and half would not. And through a number of trials showed that women who received chemotherapy, especially if they had lymph node positive disease or were younger women, the women who typically have more aggressive tumors, we could improve survival. So he, a surgeon, was the first medical oncologist in breast cancer. So I'm telling you this whole story so you understand the fundamental reasons why we give systemic therapy, why we give anti-estrogen therapy, why we give HER2-targeted therapy, and sometimes chemotherapy in the early stage breast cancer setting. It's because of these randomized controlled trials that he ran that proved we can actually improve outcomes by treating patients around the time of surgery. Can you forward the slide? So now we understand, many years later, after Bernie Fisher's original study in 1958, we are able to look at molecular subtypes of breast cancer, and we have shown that he was right, that breast cancer is not one disease. One size does not fit all. In fact, when we take tumors, this on the left is a heat map. If you take tumors from about 100 different women diagnosed with breast cancer, and you measure what genes are being expressed in that tumor or not being expressed in that tumor, we see about 5 or 6 different types of breast cancer emerge. All of these, or the majority of these tumors, are infiltrating ductal carcinoma, but you can see that there are 5 or so different patterns, back please, different patterns that emerge here. And if you look in the right upper corner right there, you can see this is a survival plot. And the patients whose tumors are in blue here, these women here, these women's tumors here, this pattern indicates these patients are going to have the highest survival long term. The women with the basal-like in the red, or the HER2-positive breast cancers here, had the worst survival. And so now we're beginning to see that this subtype, this classification system, indeed is predictive of outcome. Now, for those of you who know someone who's had HER2-positive breast cancer or who personally has HER2-positive breast cancer, keep in mind that these tumor samples were all looked at in the era prior to Herceptin. And so this is not the survival pattern we're seeing in the Herceptin era. This is just the survival pattern in a non-Herceptin treated patient population. And so now sorry, it's working a little too well. And so now we are seeing a change in how we classify and treat cancers. So on the upper row here, we are seeing that the traditional way was to classify tumors how they looked under the microscope and the organ of origin, and we would treat with chemotherapy that kills kind of all rapidly dividing cells, not only the cancer cells, which are rapidly dividing, but hair follicle cells, gastrointestinal tract cells, which is why chemo is so toxic. But nowadays, we are classifying tumors by the molecular problems that are causing them to behave badly, and we are developing new therapies that are rationally targeted toward that molecular defect, with the hope being that this will allow us to target the tumor cells and spare normal cells. And so targeted therapy, which is a term that's come out in the last 20 years now, means therapy that specifically targets and kills tumor cells. And in order to develop successfully a targeted therapy, it requires that we understand the biological reasons that cells are becoming malignant. What is that driving force? We also have to be able to identify how cancer cells are different from normal cells. And that is going to lead to less toxic, more effective treatments. So let's turn now to endocrine therapy and targeting those cancer cells that express the hormone receptors, estrogen and or progesterone receptor. Again, a little history. The first targeted therapy was really intervention against hormonal production. So back in 1890, a Scottish surgeon, George Beatson, was talking in the local pub with some of the farmers. And the farmers were telling him how when they remove the ovaries of their cows, that the cows stop lactating. George Beatson was treating a number of women who had locally recurrent, very aggressive behaving breast cancer that kept coming back in the skin and chest wall in spite of having multiple surgeries. And so he began to wonder whether there is a connection between the ovaries and the breasts. And he removed the ovaries from one of his patients and published this article here back in 1896, in which a woman who had very aggressive behaving breast cancer that kept coming back, he removed her ovaries and the breast cancer receded, and she went on to live many years later. What wasn't published in this article was that he did this on 2 additional women, and only one of them had the same response to removal of the ovaries. So that's our first clue. 2 out of 3, 2/3 women, had a hormonally responsive tumor. The 1/3 who did not probably didn't have estrogen receptor-positive cancer. Estrogen was not discovered until about 30 years later in 1920, and the receptor wasn't discovered until 1968. So most of what we are doing with hormone receptor-positive breast cancer has really happened in the last 40 to 50 years. So here's a picture I like to draw for my patients. Hormonally driven breast cancers that express estrogen receptor, comprises about 60 to 75% of breast cancer. So here's the estrogen receptor in blue. And what it is, Kim Blackwell says it's like an ignition. I think of it as like a lock waiting for the key, and the key is estradiol. So the little pink guy comes in here, locks into one of the keyholes. A second receptor has the same thing happen. The 2 receptors bind or dimerize, bound by the estrogen. They go into the nucleus and they actually sit on the DNA and turn on genes that allow the cell to divide and grow, and turn off genes that allow the cell to undergo natural cell death or apoptosis. So tamoxifen was developed to block that receptor. I tell my patients it's like putting glue in the keyhole so that the estrogen can't get in and exert its effects. Whereas aromatase inhibitors, anastrozole, letrozole, exemestane, block production of estradiol, but when given alone, only work in women who do not have an ovarian source of estrogen, so they don't work in younger premenopausal women. So tamoxifen, again, it's something that we call a SERM, selective estrogen receptor modulator. It was discovered in '62, and it competes with estrogen for the receptor binding. It's an interesting drug. We say it has partial agonist, partial antagonist activity, meaning in breast tissue it blocks the action of estrogen, but in some other tissues it mimics estrogen. It's confusing. So on the lining of the uterus, it pretends it's estrogen, which is why tamoxifen can lead to overgrowth of the uterine lining, because it's telling the uterus lining to grow, and even in 1% of patients, uterine cancer. It also acts like estrogen on the bone tissue, which is why it builds up bone and previously had been used as an anti-osteoporosis drug. And it acts like estrogen on the lining of the blood vessels, which is why it slightly elevates one's risk for blood clot, embolism, and stroke. It can be used in any age woman because it's blocking the action of estrogen on the estrogen receptor, and has been the standard of care in premenopausal women given for 5 years for the last 20 or so years. And the reason that it's the standard of care is this curve here. This is a very important curve. It's something that we call the Oxford overview, or the EBC-TCG analysis. In this, of course, you'll remember that. Oxford's easier. So a bunch of trialists came together and said, why don't we combine all the results of all the studies ever done comparing 5 years of tamoxifen to 5 years of placebo. All of these studies, women were randomly assigned to one or the other treatment. And that'll give us tons of patients to look at, and it'll allow us to power up the study to really see what kind of impact we're having on patients in terms of recurrence and survival long term. And what they showed, keep in mind here, women all started here at the 0 point. Nobody had had a recurrence, so the curve starts here. For 5 years, half of the patients got tamoxifen, half got placebo. They're at 5 years. By the way, there's like 14,000 women in this analysis. And you can see at 5 years, they stopped taking tamoxifen. There's a significant difference. The women in the placebo arm are having more distant metastatic recurrences, incurable breast cancer come back. But what's fascinating is now everyone's off tamoxifen. 10 years, 15 years later, the curves continue to separate. The control arm, placebo arm, continues to have more recurrences compared to those patients taking tamoxifen. And this is 10 years after they've been off of it, and this is called a carryover effect. Because you've given patients a therapy that may have eradicated the cancer cells at the time of surgery before they were seen as a metastasis on a scan, you have probably cured a number of patients by doing this. And the mortality curves are the same, where we're seeing more patients die who got placebo than who got tamoxifen, and those curves continue to separate. And this is why oncologists are so stubborn about wanting patients to take this therapy, because it saves lives. Okay. All right. Now you've heard some data about 10 years. Oh, everyone rolls their eyes. 5 years is enough. You know, we've got side effects to contend with. There are risks, you just told me, of tamoxifen. So why'd you look at 10 years? So there were 2 studies, the ATLAS study and the ATOM study. This is the ATLAS study here that compared 10 years of tamoxifen to 5 years of tamoxifen. And in this study, they showed that actually taking tamoxifen for 10 years, you have a 3% gain in mortality. So it is improving survival. And the reason it's improving survival is it's reducing the risk of recurrences between years 5 and 10. When you look at the risk of blood clot traveling to the lung and endometrial cancer, because you might say, well, yeah, you may be saving lives of patients who don't have breast cancer come back, but what if they're having more deaths from uterine cancer or blood clots that travel to the lung? And actually, there's still less loss. There's more gain when you add this all up together. So that is why for a woman who starts tamoxifen when she's 30, she finishes her 5 years at 35, the oncologist may have a discussion with her saying, let's consider you continuing tamoxifen for another 5 years, because we now have 2 studies suggesting that it'll improve your long-term survival to do so. Now, what about aromatase inhibitors? These are the names of them here, trade name and generic name. They began testing in the 90s, and as I stated earlier, they're only appropriate for women who do not have an ovarian source of estrogen, because they block production of estradiol from peripheral sources, the conversion of fat to estrogen by an enzyme called aromatase. So if your ovaries are spewing out a lot of estrogen and you block a smaller source of estrogen production, it's not going to have any impact. There are multiple randomized phase 3 trials with over 24,000 women enrolled that compared tamoxifen to an aromatase inhibitor. And if you look at all of the studies, there's anywhere from a 2 to 6% improvement in recurrence rates with the use of aromatase inhibitors. All of these women were postmenopausal in these studies. And there is, to date, no significant change in survival, but it may be that we need to follow these women 10 or 15 years before we start to see survival benefits, because we have to wait for the breast cancer to come back and all of that. So the current standard for aromatase inhibitor is 5 years if a woman is postmenopausal. A lot of women are keen on the data that show 10 years of tamoxifen is better than 5 years. So I have patients coming in who say, should I continue the aromatase inhibitor for another 5 years? And we don't have the answer to that. We don't have that study out yet. We're awaiting the results of 3 large studies that are looking at 10 versus 5 years of an AI. Many of my patients, though, are quite relieved that they can complete at 5 years, because these drugs are fraught with side effects, of course, and we'll talk about that in our next session. So here's kind of the scale I think of when I'm looking at AIs versus tamoxifen. Tamoxifen has a lower risk of osteoporosis, a lower risk of this musculoskeletal syndrome or joint pain and achiness that occurs with AIs, and it's cheaper. It's off-label. And then for the aromatase inhibitors, you have a lower risk of blood clotting and stroke, endometrial cancer, and a slightly lower risk of hot flashes. All of these, both of these types of drugs cause these problems, and so it's a bit tricky. You have to talk with your oncologist about the side effects and how you're tolerating it, and I would say probably 40 to 50% of my patients start on one drug and have to switch to another to try and mitigate the side effects they're experiencing. Okay, I'm not having luck with this. All right, so for hormone receptor-positive breast cancer, the standard of care, we know that hormones are a driving force of the cancer. And so hormonally targeted therapy saves lives long-term and prevents stage 4 incurable cancer. The thing about ER-positive breast cancer is there is no magical, if I made it 5 years, I'm cured. This cancer can come back at any time later. And so doing the hard work those first 5 or 10 years and taking the therapy is going to substantially improve one's long-term chance of not having cancer come back. Tamoxifen for 5 to 10 years for premenopausal women, and AIs for 5 years. So the SOFT trial is a study that recently came out. You might be aware of this. And this is a study that was just published in the New England Journal of Medicine this past year. And this was a study to actually look at the use of aromatase inhibitors in premenopausal women. I just told you we can't do that. But the way that we do that is you render the person postmenopausal by giving an injection to turn off the ovaries. So you're looking at 2 therapies compared to 1. So this study looked at tamoxifen alone for 5 years. Over 1,000 patients were assigned to each arm. Tamoxifen plus an injection called triptorelin for 5 years. So this is addressing the question of if we block the estrogen receptor and turn off the ovarian production of estrogen in a young woman, will that improve outcomes? This has been very controversial over the last 10 years. Or an aromatase inhibitor plus ovarian suppression for 5 years. There are patients who have co-expression of estrogen receptor and HER2, called triple-positive breast cancer. About half of patients with HER2-positive breast cancer also have ER-positive breast cancer. I want you to be aware that only 11% of the patients in this study had HER2-positive disease. So for my patients who are ER-positive, HER2-positive, I can't exactly extrapolate the results of this study and say we know that it's going to impact them the way that the overall study did. I'd just like to make that point. So in this study, they were looking at disease-free survival. So the survival of the percentage of patients who survived without cancer coming back. And it showed that in all the treatment groups, all 3 treatment groups, it was about the same. However, if you look at tamoxifen added with the ovarian suppression, so the injection that turns off the ovary, it was a non-significant improvement in outcomes. So tamoxifen versus tamoxifen plus ovarian function suppression is about the same. But when you look at exemestane plus ovarian function suppression versus tamoxifen, there does appear to be a trend toward reduction in breast cancer recurrence. And so if you look at who is really deriving benefit from having the aromatase inhibitor plus ovarian suppression, on the left side, these are patients who did not receive chemotherapy, and they are no different whether you receive tamoxifen alone or exemestane plus ovarian function suppression. The patients who received chemotherapy, however, seem to do much better if they receive exemestane. It's actually reducing their relative risk of recurrence by 35%. The absolute difference in recurrence is, so 86% of patients with exemestane were free of recurrence, 78% who took tamoxifen. So why would prior chemotherapy have any influence on whether or not a patient would respond better to exemestane? And the answer is patients who got chemo had worse behaving disease, higher grade breast cancer, larger breast cancer, lymph node positive disease, probably younger. And that is why doing the more aggressive hormonal intervention is probably having more of an impact. Okay, so what may be coming soon for ER-positive breast cancer? We're going to look, most therapies are first evaluated in patients who have stage 4 breast cancer, metastatic disease. So I realize we're focusing on early breast cancer, but in order to see what's being studied in the early stage breast cancer setting, we have to reflect on recent updates in metastatic setting. And so I'm going to talk about the CDK4/6 inhibitors. This here, I know it's dizzying, just bear with me, I'll explain it. This is the cell cycle. This is the process that a cell must go through in order to turn from one cell into a second cell. First, it has to enter into this state where DNA is replicated. So the DNA of the cell has to be perfectly duplicated, and then the cell needs to undergo mitosis. M phase. And then there are 2 gap phases here, gap 1 and 2, which they used to think were resting phases, but in fact a lot is going on to prepare that cell for cell division. We know that cancer cells do this cell division process, go through the cell cycle much more quickly than normal cells. And so scientists have studied this cell cycle and looked at what is controlling the cell cycle. And we know in normal cells, this cell cycle, cell division, is very tightly controlled, because if the cells were dividing all the time, we'd be covered in tumors. So there is this one checkpoint called the R point. It is called R because it's called the retinoblastoma protein. And the R point is a big stop sign. It tells normal cells, do not go into DNA synthesis. You are not dividing. It's a huge stop sign. There are some proteins called cyclin-dependent kinases, and the 2 we're looking at are cyclin-dependent kinase 4 and 6, and they come along and they knock down the stop sign. They knock down the R point, and they tell the cell it's time to undergo cell division. So some different drug companies looked at this and said, it's possible that there's too much of this CDK4/6 activity here in cancer cells. So drugs were developed to turn off this so that the stop sign could remain upright and intact. And we received one of those in our laboratory at UCLA. We have a panel of 51 breast cancer cell lines. Some are triple negative, some are HER2 positive, some are ER positive, all the different subtypes of breast cancer. And in Petri dishes, we treated them with the CDK4/6 inhibitor. Going into this experiment, we assumed that those cancer cells that are dividing the fastest, triple negative, HER2 positive, would be most sensitive to inhibition of CDK4/6. And so what we saw, each of these is a little cell line, and when the column is lower, it means they died. There were fewer of them left here. So you can see that there was a group that just kept on chugging along and dividing, even when we treated with the CDK4/6 inhibitor. There was a group that had intermediate sensitivity, and then there was this group that was highly sensitive. And when you look at the most highly sensitive cell lines that we saw, they were almost all ER-positive luminal subtypes, slower growing, better behaving breast cancer typically. That blue curve I showed you early on when I showed you the heat map. And the triple negative basal-like were quite resistant. So we now understand this a little bit better, and we understand that ER-positive breast cancer is more reliant on CDK4/6, which is why it's more sensitive to this drug, whereas triple-negative breast cancer, that R point is not as important. They have other ways of getting the cell to divide. Okay, so we took this drug into phase 1 testing. This is the phase 2 design, but the phase 1 study was in patients who were recently diagnosed with ER-positive metastatic breast cancer. They'd never been treated. We treated like 18 of them with letrozole, an aromatase inhibitor, plus the CDK4/6 inhibitor, which is an oral drug. I still have one patient on that study who I see in my clinic monthly who's been on this combination for 6 years. Her disease has not come back. So it's a pretty effective regimen for some patients. This is the phase 2 design where half of the patients received the letrozole alone and half to receive this drug. It used to be just given a number. It's now known as palbociclib or Ibrance. Given letrozole plus this drug, and then we followed them to see how many recurred. And what we saw was, that the patients who received the letrozole alone, 50% of them had their cancer progress by 10 months. And for the women who received the palbociclib in addition to the letrozole, their disease, 50% of them had their disease progress at 20 months. That's called the median progression-free survival. So there was a doubling of the median progression-free survival, which is a pretty substantial finding in a phase 2 study. So the FDA approved this drug for the treatment of metastatic first-line breast cancer in February of this year based on phase 2 results. It was given an accelerated approval. In June, the results of the first phase 3 study of this drug were presented by Nick Turner at our American Society of Clinical Oncology, and this was called the PALOMA-3 study. And this was a study in which patients either receive fulvestrant. I haven't talked about that yet because we only use it in the metastatic setting. It's an injection. It's like tamoxifen. It's pure anti-estrogen receptor. Very effective drug, but not approved for early breast cancer. So all of the patients got fulvestrant, and 2/3 got the palbociclib CDK4/6 inhibitor. And what we saw, again, and these were in patients who had already been treated for metastatic breast cancer, so they had more resistant disease. But again, a more than doubling in the progression-free survival with palbociclib. So it's pretty exciting findings from the bench into the phase 1 setting into phase 2 and 3 clinical trials with FDA approval. There are a number of studies ongoing now evaluating these drugs in the pre-surgical setting for patients who have not yet had surgery for newly diagnosed early-stage breast cancer, and in the post-surgical setting as well in the adjuvant setting. Okay. So moving on to bone-modifying agents, drugs that build up the bone and counter the effects of aromatase inhibitors on osteoporosis. And a question came up, can we reduce one's risk of metastatic recurrence or death from early-stage breast cancer by the use of a bone-modifying agent? And so shown here is a study that just came out this summer, actually. Again, an Oxford overview, EBC-TCG. And in this study, they combined the results of all the patients who had received a bisphosphonate who were diagnosed with breast cancer. There were over 18,000 patients, and they followed these women for 10 years. And they showed that the women who had not taken a bisphosphonate, and there are different bisphosphonates. There's zoledronic acid, there is things like Fosamax and Boniva. They included all of those drugs in here. The women who had not taken it had a slightly higher risk of having cancer come back as stage 4 disease compared to women who took bisphosphonate. And that was statistically significant. Now you may say, yeah, but you need a microscope to see the difference between these two curves, and it's true. It's a small difference, but it's real. And when you look at whether or not the cancer is coming back in the bone, again, you see a statistically significant difference favoring patients who took the bisphosphonate. And when you look at the mortality, now we are seeing that there is a little more separation of that curve, that we are preventing breast cancer-related deaths in women who take bisphosphonates who have breast cancer. But this benefit appears to be restricted to women who are postmenopausal. In other words, in women who are young with high levels of circulating estrogen, the effects of the bisphosphonate on the bone don't appear to be as strong, and so it doesn't appear to benefit them. But if you shut off the ovaries with ovarian suppression, or if a woman is naturally postmenopausal, we're now seeing more of a difference favoring the bisphosphonate. And so this is something that a lot of patients and their physicians are now considering as part of their adjuvant treatment regimen. Why would shutting down bone turnover affect a woman's chance of having breast cancer come back in her liver, lungs, and bones? And the answer is that those microscopic metastatic cells that escaped the breast prior to even being diagnosed with breast cancer tend to go to sanctuary sites, and one of those sanctuary sites is the bone. The bone is a place where they can hide out. And so stopping the activity of osteoclasts, which are involved in helping those cells survive, may be impacting women in a positive way. And so this just shows that whether you look at different types of bisphosphonates, doesn't really matter which subtype of bisphosphonate you're looking at. They all appear to have similar outcomes, except for this pamidronate, which may not be as beneficial, but we tend to not use that in the early stage setting. And then there was a study that came out at ASCO this year asking the question of, is one type of bisphosphonate better at preventing recurrence than the other? And so Julie Graylow presented this looking at zoledronic acid, which is also known as Zometa or Reclast, clodronate, and ibandronate. And what she ended up showing was, oh, good Lord. There is no difference in any of those. So it really doesn't matter which bisphosphonate you choose to use. It's whichever one tends to be more tolerable. The problem with bisphosphonates, of course, is a small, like 1% to 2% risk of osteonecrosis of the jaw, which is very ugly when it happens. It's a non-healing open sore in the jawbone inside your mouth, and it's highest risk in women who have very poor teeth, who need dental extractions, need their teeth removed, or dental implants, and because you're stopping bone remodeling, it can't heal. So patients who I'm putting on a bisphosphonate, I make sure they're seeing their dentist at least twice a year, brushing and flossing twice a day, and taking really good care of their teeth. Okay, let's move on to HER2, the last part of our talk here. HER2-positive breast cancer, it was discovered in the 1980s by my mentor, Dr. Slayman, that about 20% of patients with breast cancer, their breast cancer is characterized by overexpression of this HER2 receptor. Normal cells in our body have about 20 to 50,000 receptors per cell, but when there is a genetic mutation that leads to amplification of the HER2 gene in the nucleus, that leads to overexpression such that up to 2 million receptors are seen per breast cancer cell. And when those receptors come together and knock together, they activate one another and turn on signaling pathways inside of the cell that make the cell divide and grow and turn off the cell's ability to die. What is the significance of HER2? Well, Dr. Slayman showed in his science paper in 1987 in a cohort of women with stage 2 breast cancer that those women whose tumor was amplified for HER2 had a median survival of only 3 years compared to those women who did not have HER2 amplification in their tumor, and they lived 6 to 7 years. So this was the first time it was shown that that genetic event is associated with poorer overall survival. And it would have been a sad story with that survival curve I showed you earlier looking so bad if the trastuzumab monoclonal antibody that targets the outside of the HER2 receptor had not been developed. And this drug is a protein antibody that is engineered. It's given intravenously and goes around and attaches to those cells that are overexpressing the HER2 receptor. So what kind of impact has trastuzumab had? Well, the first studies, of course, were done in the metastatic setting. There was a 469-patient clinical trial in which half the patients received chemo alone for their metastatic HER2-positive breast cancer, and half received chemo and trastuzumab. And the response rate, the percentage of patients who had the disease shrink, the progression-free survival, and the overall survival was significantly better with trastuzumab, and these data led to the FDA approval of this drug in 1998 for patients with metastatic HER2-positive breast cancer. Now, just a side note, there was a big argument around this. If anyone's interested in history, the book called HER2 by Robert Bazell, B-A-Z-E-L-L, he was an NBC News correspondent, is a great weekend or plane ride read. It is, if you think that science is boring and it's a bunch of great guys hanging out together, figuring out how to treat cancer, you're wrong. It's really crazy how mean they are. But there was a huge fight over this study. It was going to be a 469 patient study, but there was this big argument because some people wanted to enroll patients with HER2 normal disease, HER2 negative disease. And had that fight been lost or won by those people, and only 20% of the patients on this trial had HER2 positive disease, it would have been so diluted that we wouldn't have seen any benefit in the patients who received the trastuzumab. So it's important to keep in mind when we're looking at targeted therapies that are targeting something molecular seen in a cancer cell, that we restrict the patients that we enroll in these trials to those patients who have that molecular alteration. So I showed you that really ugly curve earlier showing that HER2-positive breast cancer without trastuzumab has a very poor prognosis. And what's happening now is curves are coming out following women who've received trastuzumab. And what we're seeing is that HER2-positive breast cancer patients who receive trastuzumab are now having a longer survival than patients with HER2-negative disease. So the trastuzumab therapy has literally altered the natural history of this disease, which is great news. What about for early-stage breast cancer? Well, there were 3 large clinical trials done with over 12,000 patients enrolled that compared chemotherapy alone to chemotherapy plus trastuzumab. One study looked at a non-anthracycline-based regimen, the TCH regimen. The reason that this was looked at is the adriamycin, is associated with leukemia, myelodysplasia, and heart failure in a small but significant percentage of patients. And so the question was, can we avoid giving the anthracycline and have similar outcomes? And indeed, the BCIRG-006 study did show that. And so curves now are coming out in early breast cancer as well, similar to the one I just showed you a few minutes ago. Shown here from this Italian registry data are women in red here who had HER2-positive early-stage breast cancer who did not get trastuzumab, and their survival is worse. Those women who had HER2-negative breast cancer are in blue, and the patients who are living the longest and doing the best are the patients with HER2-positive breast cancer who received trastuzumab. So it's a great story, and it's been estimated now that 120,000 patient life years have been saved because of this drug. All right, so this year, what's the update? Extenet came out. This is a study to look at whether, because we give trastuzumab for 1 year in an early stage setting, and there was a study of trastuzumab for 2 years compared to 1 year, and 2 years was no better, which is why 1 year is the length of time we give patients trastuzumab. So this study came out to look at a new drug called neratinib. Neratinib is a pill that you take that irreversibly blocks the inside of the HER2 receptor, as well as another receptor called HER1. And this study looked at giving the neratinib for a year after women had completed their 1 year of adjuvant trastuzumab. So patients got either the neratinib or placebo, and they presented the 2-year follow-up data to look at the recurrences at ASCO this year. And what they showed was about a 2.3% improvement in the risk of breast cancer coming back as invasive breast cancer for patients who receive neratinib. But if you look by hormone receptor status, the improvement seems to primarily be in those patients with hormone receptor-positive, HER2-positive breast cancer. And there's some reasons that may indicate why that is that I don't have time to go into today, but it's an interesting finding. The problem is that the diarrhea is the most common toxicity. This drug can make patients literally melt. And so Imodium needs to be given, sometimes Lomotil, sometimes even stronger drugs to prevent diarrhea. And the question comes, should we be giving women, all women who've done their year of trastuzumab, a whole year of therapy for a relatively small benefit if it's going to make them have diarrhea all the time? I mean, we have to think of quality of life. So this has not yet been FDA approved. There is another study that's ongoing right now that is looking at whether giving women Imodium up front with the neratinib will make that side effect go away and make it more tolerable. And I believe the FDA wants to see that tolerability data before generating an approval. We also don't have overall survival data from this study, so we don't know if women are living longer. So I think important questions need to be addressed before this is ready for clinical prime time. All right, neoadjuvant setting. This is the last bit here. Why do we talk about neoadjuvant systemic therapy? So what is neoadjuvant? Neoadjuvant is giving the medicine, the chemo, the trastuzumab prior to surgery, as opposed to giving it after surgery. And there are a couple of advantages of doing it. First of all, we know if you give it prior to surgery, women live just as long and they have similar recurrence rates as if you give it after surgery. Another reason is it allows women who might have to have a mastectomy convert to a breast-conserving surgery, a lumpectomy. They might be able to save their breast, and we have lots of studies that show this is indeed the case. It also allows scientists to analyze what's going on in the breast tissue. We can do a second biopsy to see what's happening to the tumor, which is why a clinical trial that does a neoadjuvant design is really good, because it allows us to see in vivo, in the body, what molecularly is happening with that new drug we're testing. One thing that patients love is you can see the tumor melt. When you do the treatment after surgery, the tumor's out of your body, and you're going to say to your doctor, how do I know this is really working? And we are going to say, we don't. We are basing it on prior trials that show patients do better. If you give the medicine while the tumor is in the body, you can actually see the tumor responding, and if it's not responding, you can alter the treatment. And finally, we know that patients who achieve a pathologic complete response, meaning no tumor is found at the time of surgery after having therapy, have the best survival. So it's prognostic. We know that not all tumors are appropriate for neoadjuvant therapy. If you look at our hormone receptor-positive, especially low-grade HER2-negative tumor, there's only a 7% chance that all the tumor would be eradicated by giving chemo prior to surgery. This is another meta-analysis that the FDA did. HER2-positive, hormone receptor-negative has a very high chance of having the tumor go completely away at the time of surgery if they get trastuzumab. And triple-negative breast cancers also are very responsive to chemo and have a high chance of path CR. So often neoadjuvant therapy is only going to be offered to these two subtypes of breast cancer. And we know that patients who have HER2-positive breast cancer who have a pathologic complete response in the blue are living longer without their breast cancer coming back, so it's prognostic. And because of this, the FDA has said if you want to evaluate new promising therapies in early stage breast cancer, you can do so in a neoadjuvant clinical trial. It'll be a shorter clinical trial, you'll get your path CR rates quickly, it'll be a smaller trial, and this will allow patients to know when a therapy is promising and will allow us to approve it for use earlier than waiting 5 years to see how many patients survive. So there is a therapy called pertuzumab, and I'm going to explain how it works here. This is the HER3 receptor. HER2 gets going, its signaling gets activated by mating with HER3 or HER1 or itself. That mating is called dimerization. So I'm going to show you what happens between HER2 and HER3 because they like each other a lot. They're the preferred partners. So here is a ligand called neuregulin that binds to HER3. That makes the receptor dimerize, and it opens up this binding site here that HER2 likes to bind with. When HER2 and HER3 bind, it turns on this intracellular signaling pathway that sets about all of these events here that make the cell divide and grow. Herceptin, or trastuzumab, binds over here and blocks HER2 over here. But there is a new drug called pertuzumab that binds right here and blocks this mating here. So a number of studies were done to look at those two antibodies given together to see if they work well together. And they indeed did in the laboratory. And so a phase 3 study called Cleopatra was done, looking at trastuzumab and chemo versus giving the two antibodies with chemo, hitting that HER2 receptor twice and giving it with chemo, and showed that the overall survival was significantly improved by using pertuzumab with it, and that led to the FDA approval of this new antibody in 2012. Neoadjuvant setting. In the neoadjuvant pre-surgical setting, this antibody was also evaluated. There were two studies, Neosphere and Trifina, and these two studies are small studies with short follow-up, but they led to the FDA approval of pertuzumab in the neoadjuvant setting. This is the first study, about 100 patients per arm, and looked at giving chemotherapy with trastuzumab, chemo with the two antibodies, trastuzumab and pertuzumab, just the antibodies alone without chemo, or docetaxel and pertuzumab, and then go to surgery and see how many patients in each arm had their tumor completely disappear or pathologic response. And what they showed was that patients who received two antibodies with the chemo had the highest rates of pathologic complete response. They followed just this June, they presented this data, presenting the progression-free survival, meaning looking at these patients long-term and seeing which patients had the highest chance of being alive and free of cancer recurrence. And the study wasn't big enough to really look at this, but the trend is showing that the patients who got the two antibodies with chemo are having the longest progression-free survival. So the patients who had the three treatments were doing best. So the Neosphere study showed that THP tends to be the best. Patients who had PathCR had a better outcome. And this supports the use of PathCR as an endpoint in clinical trials to evaluate new therapies. The second phase 2 study was Trifina, and this was a 3-arm phase 2 study looking at two anthracycline-based approaches. Epirubicin is like adriamycin, with the two antibodies, or this TCH, non-anthracycline regimen I told you about, plus pertuzumab. And what it showed was the pathologic complete response rate was quite high in all of these, numerically was highest in the TCHP arm. And so in September of 2013, the FDA approved the first neoadjuvant regimen in breast cancer. These are the 3 approved regimens for patients with HER2-positive breast cancer of at least 2 centimeters in size. And what we tend to do at UCLA is TCHP, because then the patient is completely done with chemo prior to surgery, and after surgery doesn't have to go on and get further chemotherapy. And then the final thing is TDM1. This is a magical little molecule here. What this is trastuzumab, stably linked to one of the most potent chemotherapy agents known to mankind, a derivative of maytansine. Maytansine is too toxic to be given alone, but when stably bound to the antibody, it doesn't exert its effects or have any effects until the trastuzumab binds to HER2. This is all taken up into this lysosome. It's internalized into the cell, and in the lysosome, the pH changes and some enzymes clip that linker and release the maytansine into the cell, and then the cancer cell is killed. So it's the first targeted delivery of chemotherapy. It doesn't even cause women to lose their hair, and yet it is potent chemotherapy. This was evaluated in a phase 3 study in the metastatic setting where TDM1 was compared to a standard lapatinib capecitabine regimen, which was a standard regimen in the second-line setting, and it showed that TDM1 had a better survival, better response rate, progression-free survival, and the most important thing, better safety and quality of life. And so studies are now looking at this drug in the early breast cancer setting. Can we get a woman through treatment, adjuvant treatment, without losing their hair and having the same curative approach? So this drug was approved in February of 2013 in the metastatic setting. Nadia Harbeck at ASCO presented the first neoadjuvant study of this drug, and what she did was she restricted it to patients who are HER2-positive and ER-positive and compared TDM1 plus anti-hormonal therapy and aromatase inhibitor, or trastuzumab with hormonal therapy, so no standard chemotherapy given. 4 cycles, and then they went to surgery. Oh my gosh, what the heck? Help me. Someone help me. And what they showed was the TDM1 alone arm had a 40% chance of pathologic complete response, TDM1 plus endocrine therapy 45%, but the down, we're at the tail end. Keep going. There we go. And it's 79. Okay. Thank you. And trastuzumab and endocrine therapy was the loser here. So these women, keep in mind, 40 to 45% of them had not lost their hair, had not thrown up, had not had diarrhea. They got 4 cycles of therapy, and they couldn't find tumor at the time of surgery. I mean, that's phenomenal. So we designed a clinical trial called Christine. We opened it in June of last year. It's a 432-patient study. We closed it in May of this year with 444 patients enrolled in the world, comparing that TCHP arm, which was FDA approved, versus TDM1 plus pertuzumab. There's no TDM1 alone arm. We wanted a TDM1 alone arm, but the sponsor couldn't afford it and didn't want to do that. So this is the design. Patients go to surgery after getting their 6 cycles of therapy, and we're measuring the pathologic complete response rate. So we're expecting to present these results. Keep in mind, we closed the study in May, and we're going to present the study in June of next year, the results. If this shows either an equivalent outcome to standard chemotherapy or better, you may see an FDA approval for early-stage breast cancer for the first regimen that doesn't cause hair loss or the kind of toxicity that chemo does. Had this been a study done in the adjuvant setting after surgery, we'd have to wait 3 to 5 years to see who recurred. So now you kind of understand why neoadjuvant setting is an exciting place for clinical trials. Okay. Summary, ER-positive breast cancer, do your hormonal therapy. It saves lives. It's important. We'll talk about the side effects and mitigating those. AIs are the preferred agent for postmenopausal and for select high-risk premenopausal patients, but ovarian suppression is needed, and it's important to note that estradiol levels need to be checked monthly if you're getting ovarian suppression and you're a young woman, because 20 to 25% of women will have ovarian function breakthrough and not even know it, may not even get a period. So it's important that oncologists measure estradiol monthly to make sure the drugs are working. Tamoxifen and then palbociclib and other CDK4/6 inhibitors are being looked at. And for HER2-driven breast cancer, many promising approaches being looked at. And so now I showed you just this half of the curve, which is the way that we treated breast cancer until the 80s, really. And now we have systemic therapy, which is really leading to the improved survival and outcomes for patients. We have hormonal targeted therapy for women who have ER-positive breast cancer. We are still stuck with cytotoxic chemotherapy. We need to evaluate new regimens that target the delivery to cancer cells. TDM1 is a great story, and hopefully will go out to other subtypes. We need to treat the triple-negative type. And then we've got some interesting data regarding bisphosphonates. And so with that, I will stop. Thank you.
Thank you so much. So we can only take a few questions, but if you have one, please text to this number. Our people watching on the live video feed can watch as well. Remember, we'll be doing a second workshop that will focus on side effects. So if you have a question, please focus it on the medical aspect. I really think this talk shows the importance of clinical trials and clinical trial participation. So I thought maybe you might want to say a few words about that while we're waiting to see if anyone has any questions.
Yeah, absolutely. Clinical trials, the way that they're designed now, a lot of women have reticence toward going on a clinical trial because they don't want to be a guinea pig or get something less than standard therapy would give them. However, the way that trials are designed now, there is so much oversight by the FDA and ethics committees in the way that they're conducted that they are virtually error-proof in terms of always making sure a woman is getting at least standard of care and possibly also receiving a cutting-edge promising therapy. So being part of the science has two advantages. There's an altruistic advantage that you're moving science forward so that outcomes can be better for women who come after. But the more personal reason is that you're actually gaining access to a therapy that it may take 3 to 5 years for the general public to receive if it's promising. There are different phases of clinical trials. Phase 1 are the earliest evaluation where we really don't have safety or efficacy data available, and typically those trials are enrolling women who've been through all the lines of therapy and have stage 4 disease and are looking for something promising, but it typically would not be evaluated in the early stage breast cancer setting because it's a curative setting. The phase 2 and phase 3 studies are backed by more data. You can actually look at the consent and talk to the investigator and say, what data do we have on safety? What data do we have on toxicity and on how effective this drug is? And why should I participate? Do I have the right tumor type that promises to benefit from this therapy? I always tell a patient when you sign a consent to go on a clinical trial, it is not a contract. You can sign the consent, and at any time point from there on out, you can withdraw your consent. So it's not binding for you. It's a permission slip that you can redact at any time.
Okay,
so,
I'm going to just interrupt.
yeah.
I'm sorry, so many questions
Sure.
are coming in.
They're
so I
coming
wanna-
in now. Good.
They're coming in fast and furious. I just want to, there's several questions about timing of when to start tamoxifen. So do you have to start it immediately following treatment? What if you didn't do it? Can you take it later? And also, if you're a postmenopausal woman, should you be taking tamoxifen or should you be taking an AI?
So starting tamoxifen should start after radiation. If you don't need radiation because you had a mastectomy, it should start after chemotherapy or within a few weeks from your surgery if you don't need chemo. If a woman didn't start tamoxifen or an AI for a year or two for whatever reason from the time of surgery, it will still benefit that woman to start it later, and we have studies that show that. But earlier start will prevent earlier recurrences, so we encourage starting. We don't give it concurrently with chemo, and we don't give it concurrently with radiation. In terms of postmenopausal women, the aromatase inhibitors are the standard of care because they are better at preventing recurrences than tamoxifen. But as I said, there's no difference in survival at this time, and if you've gone through the gamut of AIs and can't tolerate any of them, tamoxifen is still a very good therapy, and using that would be an appropriate second approach.
Okay, great. And then there are some questions about the bisphosphonates. Do they help with bone loss?
Absolutely. I skimmed over that in the interest of time, but that's been shown time and again that bisphosphonates not only protect the bones from bone loss, which you see with aromatase inhibitors, but actually build up or counteract the effects. So women can go from being in the osteoporotic range into being in the osteopenic or even better range. So yes, it's got two effects I didn't mention. It prevents the breast cancer recurrence and strengthens the bones.
And I want to remind everyone that at the 11:30 session, there is a workshop that just focuses on the results of the SOFT trial. So, there's a lot in that and depends on the age. So if you want more information, please make sure to do that. I think we are going to have to end this session so that you all have a little bit of time for a break. But I want to thank you so much, Dr. Hurvitz. And remember, she will be back at 11:30 to talk about the side effects. Thank you. And you're kind of all the same.